I want to start with the title of a paper, editorial paper, of Professor Trapp that say, pathogenesis of multiple sclerosis. The eye only see what the mind is prepared to comprehend. This is perfect for our talk. Salvi?
What do you want to do? You can
Okay.
press
Okay.
this.
Thanks. Okay,
Yeah,
okay, you have to
yeah,
proceed.
yeah.
Yeah, we talk about multiple sclerosis, and these are the main characteristics of multiple sclerosis. The most common chronic disability disease of the central nervous system in young adults. We think that in worldwide there are more than 2 million of people affected by multiple sclerosis. And the age of onset of multiple sclerosis is usually between the third and fourth decade of life, where every people plan the future, the personal future, the professional decision. And this is a stranger disease because everything is variable. This disease can hurt you in every time, often when you are in a period of stress and after delivery. And the relapse, what we call relapse, are neurological deficits that affect the patient with a slowly progression in 1-2 days. There is a steady state, and then there is a phase of recovery after steroid or also without steroid. And this is what we call the relapsing remitting form. But most patients, after many years, have a progressive form. These forms are very terrific because there is no treatment at all, no drug treatment really effective in this patient. But what we know is that after 10 years, many patients lose the work, the job. And 50% of the patients after 25 years are unable to walk. In Italy and in the United States, we are in a high prevalence of disease and the incidence, as you can see in this cartoon. But the main characteristic of multiple sclerosis is these 3 points. Evidence of dissemination of lesion in space, multifocality, evidence of dissemination in time, relapses or progression, slowly progression. No better explanation. What does it mean? It means that until now we have no test that can say with absolutely certain that this patient have MS, like in diabetes. You do glycemia and you say, yeah, you are a diabetes. Multifocality means the dispersion in the brain of a lesion. You see indicated by the arrow, the plaque of demyelination. And as we will see later, every plaque are around a venous vessel. Evidence of dissemination in time. This is very characteristic for all forms. You see relapsing remitting form, the scale. Do you have a pointer? Oh, here? Okay. Perfect. Yeah, you can see relapsing remitting form where there is a sort of deficit, neurological deficit, and the return to the previously situation and a second relapse. This is typical for relapsing remitting form, but sometimes there is a permanent deficit after one relapse. The second form is primary progressive, where the disease has no relapse. The disease starts usually in the lower limbs and progress with motor and sensory deficit and to the upper limbs in many, many years. There is slowly loss of function. Secondary progressive form are the most frequent for me, and there is a first phase of relapse and then a slowly progression. Those are the main clinical features, and we can see visual and afferent and efferent deficit, motor deficit, sensory deficit, deficit in coordination, urinary and bowel dysfunction, and cortical involvement. That means a sort of cognitive dysfunction. And MS is a heterogeneous clinical. In MS, we put together many syndromes. You see severity and chronicity in XY axis, and you see the form called fulminant, ADAEM. That means there is only one relapse in the life. Or Marburg is a real devastating disease, and many patients died, but it's very rare. And you see isolated form where there is only one area affected, that may be the optic nerve or myelopathy. There is also benign form that are after 15 years. There is a very, very few deficit, and there are progressive form that may involve the spinal cord and the cerebral system. No other explanation for diagnosis of MS. This is very important because we have no marker of disease. Well, 4 years ago, we decided to start an active collaboration between our two centers. I'm living in Bologna and working in Bologna, and I am the chief of the Center Il Bene, Centro Il Bene, that is a center for rare neurological disease and neuroimmune disease. And we met Paolo Zamboni, who is the chief of the Vascular Disease Center in Ferrara, and we fall in love. Because because what he said were really new. I was looking for something of new because many things were not compatible with an autoimmune disorder. So I heard a lot of things about him, and I decided, me and Ilaria, to start this collaboration, this fantastic collaboration. And we started, I think, the first venous neurovascular team, where I learned a lot of things about veins. Veins for the neurology are nothing, are a tube. But now I open my mind, I see a lot of diseases that may have a venous pathogenesis. And Paolo learned about a lot of things about neurology. So it was a sort of melting pot. Okay, this was the first paper of this collaboration, published in 2009. And Paolo called this entity chronic cerebrospinal venous insufficiency. It's a new disease, I think. It's with a new etiology, and with we will see. what was terrific was that all my patients, all patients that Paolo studied belong to my MS center in Bologna. All patients that Paolo studied had 2 out of 5 Doppler criteria for CCSVI. All. This is terrible, because in medicine you may never say all, but this is what I found, what Paolo found in my population. But if you go to the literature, the prevalence of CCSVI in MS population is too much variable in different MS centers. And I think that this may be due to these 4 points. Different training plus personal learning curve of ultrasound technician, this is very important. And it's very important to have a technician and the doctor collected. No rigid application of Zamboni's criteria. Short time devoted to the detection of CCSVI. There is one center in Italy that do the examination in 15 minutes. This is ugly. I know that they don't see anything because they don't want to see anything. In 15 minutes is nothing. And the last one is different setting ultrasound machine. And what we learn is the type and location of venous malformation in a large population of MS patient. You see annulus, septum, hypoplasia, twisted membranous obstruction, and genesis. And the vessel involved, azygos, distal azygos, lumbar, jugular, and so on. But Paolo did a good job, and he found 4 hemodynamic patterns, A, B, C, D, according to the vessel involved. And I want to point the type D, that is all the azygos system affected in various segments. And we will see later, pattern D is very important for some progressive MS. Okay. And when Paolo did this classification, we went back to the clinic and we tried to correlate clinical course and hemodynamic pattern, because this was very important for us to try to colligate morphology, hemodynamics, and clinical and neurological clinic. And we found these very important things. Type D was present in almost all patients with the primary progressive form. And the type of malformation was agenesia of the lumbar plexus. It was really impressive. No vessel. The flow inverted from the up to down to up in the spinal cord. And this was very, very important. So the first correlation between vascular malformation and clinical form. And when you see relapsing remitting form, most of the F of the relapsing remitting form belong to type B. So in summary, relapsing remitting form have much more alteration in jugular vein and primary progressive in the lumbar venous system. Okay, we try to correlate MS onset, and we have the same important result. Spinal cord onset were present in almost all have type D, and optic neurites belong to type A. Yeah, and we did also treatment, and we published the endovascular treatment in a paper, in a good paper. in a good journal. And this was the population reported. It's important to say that we never change MS therapy treatment in all patients. So in order to have another bias, we keep the treatment still. And we studied 35 MS patients in the first study, 20 secondary progressive patients, and 10 primary progressive patients. And this was the items: relapse rate, EDSS, MRI outcome measure, disease severity and quality of life. And very shortly, because these data are just published, we found that the percent of patients that are relapse-free were 27 1 year before treatment, and they were 50% after the patient 1 year and a half after follow-up. And can you see? Yeah? Yeah. And if you go to EDSS, annual relapse rate, you see that there is a sort of fall in relapse rate after treatment. We pass from 0.6 to 0.38. And same for EDSS. EDS2, 1 year before treatment. This work is related to 44 patients with relapse and remitting form. Only partly were described in the previous paper. EDSS, 1 year before 2, and fall to 1.5 after 1 year. And this is very important. All relapses were associated with the restenosis of one or more veins. This was true for jugular vein, but not for azygos vein. And you see this azygos vein treated, the twisted of the azygos vein, and after liberation, you see very, very little congestion after treatment in the vessel. And this is an example of pre-liberation, post-liberation, and restenosis in the lower row. The reason of restenosis, it may be, these are absolute hypotheses, inefficient dilatation, persistence of the valve, venous valve, partial or complete thrombosis, exuberant scar tissue. But this is very important to keep in mind. All RR patients with post-procedural patency of the jugular vein and azygos vein were always relapse-free. We have a follow-up of 3 years. So it is mandatory to try to restore a normal venous outflow from brain and spinal cord. But this is very important to know. Not all patients have a treatable form of venous malformation. A patient with the primary progressive form with the genesia of the lumbar plexus, I think that will not benefit 100% from this treatment. So these cases require a new treatment strategy, and the door is open to future research. MRI outcome measure, we are only partial data, but the trend is very important. As for disease severity, quality of life, but what we found is what most of neurologists think, that this is a terrible procedure. We have deaths. We did a lot of catastrophic. It's not true. It is a safe. We have to say to everyone, it is safe. I personally follow this patient. It is a procedure safe. And the people that do this from 15 years say the same. Okay, say to your neurologist, it's safe. It's important. But what we say in this paper is this is not an open lab randomized trial. So we need further randomized control study, and we are planning in the future 2 months. This is another wonderful part of the research, neurophysiology. One of our aim was to determine and to measure the modification after the liberation procedure. And this is one of the first patients we followed. And we broke another axioma. That means that neurophysiology can ameliorate in MS patient. And in this patient we saw, after liberation, they increased the motor potential. That is terrible. No one can believe it. No neurologist can believe it. And the shortening of the potential. This is really new in medicine, that a procedure can modify neurophysiology. This is a very important portion. We talk about CCSVI. But is there a clinical pattern directly due to CCSVI? And this is it's a very important observation from a neurology field, because we followed up very strictly our patient, and we have 2 points suggesting that there is a clinical pattern related to CCSVI. So increased venous insufficiency in the brain and spinal cord, liberation procedure, and RIS, radiologically isolated syndrome. And we learn about from our patient after liberation procedure, because soon after the liberation procedure, the following symptoms changed: fatigue, headache, quality of sleep, and a working memory, indicating a cause-effect linkage with the venous hemodynamic modification. So the first step is malformation congenital. We think that these malformations are congenital. Congenital malformation in veins, drain, CNS, central nervous system, the formation of a CCSVI, and those 4 are directly related to CCSVI: fatigue, headache, quality of sleep, working memory. The first one, fatigue. No one knows, no neurologist knows why fatigue is due, exactly the cause of fatigue. And no treatment at all is effective. Mantadone is not so much effective, and it's a very big problem. But this may really be due to CCSVI. You see, more than 40% have described the fatigue as the most disabling symptoms, and 90% is from weakness, spasticity, motor problem, or bowel, or bladder problem. And we don't know nothing, but after liberation, fatigue decreased. And if we have a restenosis, the first symptoms that may happen is fatigue. This is very important. Headache. This is another very important, and I think specific for MS. We know that the frequency of headache in MS population is higher than in average population. It may accompany disease relapses. And another thing is sometimes it worsens in supine position. And this is a sort of headache that is really atypical. But we know this. We know that most of the headache in MS patients are worsened in supine position. This is important because if you go to the hemodynamics, you can see that when the patient is in upright position, you see the vertebral venous plexus draining almost all of the blood in the brain. But when you go to the supine position, you see that most of the blood is draining from internal jugular veins. If you have a stenosis in the jugular veins, you may have a big problem where we are in supine position, like you stay almost 10 hours a day during sleep. Okay, quality of sleep. This may really influenced by jugular obstruction. And a lot of patients with MS are poor sleepers. And we have much disorder related to sleep. But we know that, from the diary of one of our MS patients, after liberation procedure, I can sleep better. I feel less tired in the morning, and so I have much energy and desire to do things. Moreover, I have begun to dream again, or at least I remember my dreams, like our dreams. And this is very important because this improvement of quality of sleep is sudden after liberation. The same night, in almost all patients, they sleep well. Working memory. Working memory is another important factor ameliorating in after liberation procedure. And you see that patients have more attention, are really make less intellectual fatigue after in the job. And this was in this cartoon you see before and after liberation, Superman. This is what we learned from after liberation. But there is another point that is very important. We have patients with who did MRI for many reasons, and radiologist said, yeah, Dr. Salvi said, plaque, MS, but I'm feeling good. What does it mean? There is a phase of the disease, of the what they call pre-MS, where you haven't the characteristic to have a diagnosis of MS. And you haven't the characteristic to have the diagnosis of CIS. That means clinical isolated syndrome. But you have only one MRI altered. So this is the condition where you do an MRI for some reason, and you say plaque. And this is a terrible thing, because you don't live no more, because you have in the mind, I may have MS, like in this cartoon. Radiologically isolated syndrome is a recent defined entity described as the incident discovery of lesions suggestive of MS on brain MRI scan, demonstrating dissemination in space without symptoms, expression, and with a normal neurological examination. But this is not true. If you go to the reason for doing an MRI, you see headache, fatigue, quality of sleep altered. So this may be the expression risk of CCSVI. And you haven't neurological deficit. You have in almost of this patient, you have evoked potential normal, and you haven't oligoclonal bands. Fatigue. So the long travel of CCSVI to MS. Risk, that may be the real expression of CCSVI, CIS, the onset of MS, and you see relapsing remitting, secondary progressive or primary progressive, and this syndrome may be related to the location and type of obstruction in the venous vessel. Malformation, CCSVI, the formation of a plaque and the normal appearing white matter. The plaque are always venocentric. This is what found Sherlock Holmes. And I'll show you the plaque. Those are periventricular plaque, and you see the venous vessel, and if I do up and down, you see that all the plaques are venocentric. And this is in the middle. Okay. This is corpus callosum, and you see the vascularization of corpus callosum, and the lesions are also in this case perivenous. This is spinal cord, and you see the venous anatomical structure of the spinal cord, and you see a plaque resembling the venous area draining. But you see also in cortical lesion in MS that all the lesion, there are 7 types of different lesion, and the majority of this lesion are around the cortical veins. So this is another mistake that may be solved. What we found in advanced stage of disease, we found 2 more problems. The first one is iron storage in the parenchyma. The second, what does it do with the CSF, cerebrospinal fluid, when the venous, in presence of venous insufficiency in the brain? And we go on. Iron storage in diminution plaque. This is a picture of Zamboni. This is the iron around MS plaque. So it's not casuality, like many neurologists say. Degeneration, oh, okay, quit. Help me. So many neurologists said that the accumulation of iron in the brain is present in almost all neurodegenerative disease. I think that Dr. Ack is not in agreement with this hypothesis. So it doesn't matter. It's very few, and it is not clinically important. Fatto? Okay, forward. We know from the literature that this is not true. It is maybe present in almost all patients, and we will see more MRI cortex of Markaki, and you see the accumulation of iron in the pulvinar and in the basal ganglia. But I think it's not absolutely related to inflammation. And you see in the slide the accumulation on substantia nigra. And I saw extrapyramidal signs in a MS patient, as you see in this cartoon. It's very rare, but you can find, if you look for extrapyramidal sign, a Parkinsonian syndrome in patient with MS, no rust, and you see my cartoon. And the other things is what happened in the cerebrospinal fluid when you have a CCSVI. You see the venous engorgement, and you see CSF with the high pressure, because CSF drain into the vein. And we studied with Professor Zivadinov in a project called 40,000 miles for a therapy. And we see a lot of wonderful things regarding CSF relationship with MS. This is a neurological syndrome called normotensive hydrocephalus, where there is a triad with a cognitive decline, gait is small step with a larger base that resembling magnetic gait, and the urinary incontinence. This is normotensive hydrocephalus. This is my patient. And you see with the time, 2005, 2008, 2009, 2010, you see the lateral ventricles increase in size over the time with a normal, pretty normal cortical volume. So this is very important because we can do something in this patient. And when I talk with the neurologist too, they say, yeah, cognitive decline is a part of MS. Gait is more step is a part of MS. Large base urinary incontinence is part of MS. Okay. But we can see, if we see together, they may have a solution. Normotensive hydrocephalus. Okay, looking forward. What we are working now is the creation of a multidisciplinary team, like our team, in each MS center. The characteristic of MS center is to have a 360-degree mind open, because we need a neurologist, interventional radiologist, and Doppler technician able to work together. It's not really simple. Research protocol, therapeutic multitask, and the last one is a spy story in MS Word, is a new one. So, multidisciplinary team, and you see in this cartoon, yeah, those are three crazy men working together. Zamboni, Salvi, Galeotti. Working in progress. And therapeutic multitask. So this is very important because we have many steps. We can find malformation in vein and treat them. I don't know if it's correct or not. We may wait for a RACE, radiological accelerator syndrome. When there is no deficit, neurological deficit, we can wait for CHIS when there is the first neurological event, or we can wait for MS, RR, PP, or SP. So the best thing to do is to confirm the result of liberation procedure. If the results are really good, we can go on to do this liberation procedure. But we have to keep in mind that there are other factors. Venocentric inflammation. Inflammation has to be treated. So we never say interferon, Copaxone are devil. Never. We never take off the drugs. And this is very important to keep in mind. Say to our neurologist, Dr. Salvi say that the disease, the drugs has to remain. The second is iron storage in the parenchyma. And we are planning a new research regarding chelation. And normotensive hydrocephalus, when present, we have to treat. So the treatment I need to improve as CCSVI, immunomodulatory, immunosuppressive treatment, treatment to improve CSF outflow, treatment for iron deposition in the CNS. And we start a new page, spy story in MS Word. Sherlock Holmes knows everything about the brain, but Sherlock Holmes needs to know that there are other areas very interesting in MS Word. The first one is thyroid gland, and the second the eye, because these are organs involved in venous circulation, supply of venous circulation of the brain. And you see thyroid gland. And you see how in many patients there is sort of circle of the involvement of the thyroid vein as a form of a shunt. If you have an obstruction, like, as you see here, here you may have a shunt. And thyroid is the first organ that may be influenced in this pathway. And this is very important because this is before and after treatment. You may see that there is a sort of a congestive thyroid. And after treatment, thyroid function, in most cases, go to the normal. Multiple sclerosis of the eye, retinal vein sheathing, and pars planitis. These are two entities that have never been studied fully in MS patient. And this is very important because all these problems are venous problems and are due to and are related to CCSVI directly. As in this paper of Neurology 2007, diagnostic accuracy of retinal abnormality in predicting disease activity in MS. Make a sense or not? With the view of CCSVI, yes. Retinal nerve fiber layer atrophy and the presence of retinal peripheral light are associated with disease activity, suggesting that retinal evaluation can be used as biomarkers. Venous vessel, crazy. Okay, this is another paper in 1972, where they say shading is seen as a fine opaque border of the vein on the retina, and is thought to be of significance in relation to multiple sclerosis, only if it has occurred at distance from optic nerve head. Many conditions such as papillitis and papilledema may cause shading of the veins at the nerve head. So this is not the case. And this is what is our venous neurovascular team in Bologna-Ferrara. You see the picture of 3 crazy men followed by other crazy men. So the last slide is a summary. CCSVI and MS are tightly connected, and the vascular treatment of venous stricture is effective on neurological signs and symptoms of MS. And the last one is the best. Venous neurovascular teamwork is necessary to better understand MS. Thank you.
Okay, we can go home now. Yes, Mark.
Fabrizio, thank you for a very nice presentation. I wanted to add something to one of your comments. There's a paper in 1991 by Cameron from the American Physiological Society, and he did some testing on diabetic rats and demonstrated that if you decrease, they have decreased blood flow, they also have decreased nerve conduction rates. And if they treated these rats with bottle
Yeah, I think you are perfect. Yeah, we saw a lot of things, a lot of research, a sort of puzzle. Because if the dominant opinion is that MS is an autoimmune disease, what is that? Nothing. So it has to be erased. Forget it. But if you say that this disease is the result of a vascular problem, all this data can link together. And there is a sort of magic order. And is a new key to open the mystery of MS.